Yeah, Alex?
Yes.
We're missing Dr. Caldwell. We didn't realize that until just this moment.
Does anyone know his location? Any of our colleagues there?
Martha said he was either going to be in his office or the conference room.
Okay. May I ask who else is in the room there, just so I know?
Stephanie, IT, and
Blake, IT as well.
Blake with IT.
Okay, so none of the health department staff other than those two individuals?
I don't.
These are the important people. Got it.
I don't know where Martha's logging on. If she's
Okay, I see Derek, you're on. I see that. Right.
And Carol has gone to.
I am on. This was Derek.
Yes, sir. And
This is Dr. Caldwell. Can you hear me?
Yes.
yeah, perfect. Perfect.
Oh, great. We're this is just one laptop here. We're trying to get our other technology set up, but I'm in the directors conference room here with a number of the ELT colleagues.
All right.
So we're we have a couple of our technical colleagues who are trying to get us set up properly. So thank you for your patience, and we'll let you know as soon as we're connected.
We can hear you pretty well. Is there more that needs to happen?
Is that working now?
We should be, yes, hello, hello?
I think we have a quorum.
Did you mute yourself?
Stephanie, we're good.
Laptop?
We're broadcasting, Stephanie, so everyone who would like to join in can hear.
Yes.
Great. All right. Well, I will call this meeting to order. There is a motion that is written to approve meeting by electronic means that are in your packet. I would appreciate if somebody could make that motion so we can have this meeting appropriately electronically.
What's going on? Okay.
Anyone?
This is Dr. Johnson.
Any of my fellow board members?
So moved.
No,
All right.
it shouldn't have.
Can you mute your phone if you're not a board member, please, currently? Thank you. So did I hear Dr. Johnson made a move to approve the motion which says a motion that the items on the meeting agenda constitute essential business of this board meeting electronically is necessary to protect the health, safety, and welfare of Tennesseans in the light of the COVID-19 outbreak. And any board rule that conflicts with the governor's executive order 16 permitting electronic messages be suspended. Is that the motion you made, Dr. Johnson?
It certainly is. Thank you.
Yeah, we're just trying to get a couple of technical issues.
All right. Is there a second to that motion?
I second.
Is that Dr. Caldwell or Campbell? Excuse me.
Yes.
Okay. All right. So I will do a quick roll call. Dr. Johnson.
Here.
Okay. So let me rephrase. I apologize. So the motion and a second has been made to approve the conduct meeting by electronic means. Is there any discussion around that? Okay. Hearing none. This is a yay or nay vote. Dr. Johnson.
Yay.
Dr. Campbell.
Yay.
Mr. Frederick. Mr. Frederick. Okay. Ms. Franklin.
Yay.
Mr. Frederick. I see you all from mute now.
Yay.
Okay. And Ms. Etherington.
Yay.
Great. All right. That motion carries. Thank you. Dr. Caldwell, are you in a place where you could do your report now?
Can you hear us now?
Yeah. Actually, before that, I apologize. Before the report of the director.
So maybe I guess we should just go back.
We can hear you. Okay. Team, focusing back, there is a deliberation of end date of declaration of public health emergency. If you remember at our last board meeting, the public health emergency that we declared in March, we set a sunset date of the end of May. Every order that has been issued from Safer at Home to now the phased reopening falls under this public health emergency. And in order to continue all of this public health emergency declaration would have to be extended. As context, the governor extended his executive order that's similar to this until the end of June. And so what I would like to have a deliberation and possibly a motion on at some point is do we let this sunset end of May? If not, do we extend it, and for how long? So that's how I'd like to tee up this conversation, and I open the floor to any of my colleagues that would like to discuss this.
Alex, I'm sorry, we're sort of adjusting to here. Just state the very specific point that we are going to discuss about May 30, at the end of May.
Yeah. So, as the public health emergency that we all approved in March on the end of the month, our last board meeting we extended it until May 30. 31 months. 31 in this state. So the end of the day, right, Derek? End of the month, May 31st. As it currently stands, unless we approve to extend it, yep. If we do not extend it, on May 31st, the public health emergency, which authorizes Dr. Caldwell to do the orders that he's done, goes away. If we would like to extend it, perhaps, I mean, I would say we evaluate this each month, frankly. That'd be my bias in this, and extend it till maybe June 30th, changing nothing else in the order other than the date of sunsetting as June 30th. And that will allow us at the next board meeting to, again, evaluate if this is still a needed declaration, the declaration of public health emergency. So the main reason it's here is if we do not do anything on it, it'll expire on May 31st, and any order that has been written under this public health emergency by Dr. Caldwell will be expired.
Well, I think it would be not a good idea to fail to do it in step with the governor.
Well,
Just my opinion.
If we didn't extend, what is the, as best we can know, what impact would that have on compliance with phase 1 moving into phase 2?
Well, if you don't extend it, then there would be no such thing as phase 1, phase 2, phase 3, phase 4, because all those are done under orders that fall under the public health emergency. So it would all go away.
So in order for us to appropriately go through the phases and continue the safety measures laid out that the task force has worked so diligently on, I think what I'm hearing is that it would benefit us to extend till June 30th. That way we can continue the phased opening of Nashville, Davidson County, correct?
Yes, ma'am. And I like June 30th because it then allows the board every month to have this discussion to ensure that we want to continue the public health emergency declaration. That's correct.
Okay, and the flip of that is that should we decide to go to June 30th, and there's a wonderful event that says we are really in good shape sooner, can we in some way, well, we would have a meeting the second week of June, so I guess we could decide again.
That's right, and that's why I think a monthly, and I think that's why a monthly approach would be a good way to approach this. And let's say miraculously all COVID just goes away and we decide, you know what, we no longer want to have a public health emergency. Dr. Caldwell could rescind all his orders or his own if he so chose. But I mean, these are all hypotheticals, right? But yes, you're exactly right. At the second week in June, that's why my recommendation would be a motion just to extend it by 1 month only, so that the board will have oversight every month on this declaration of public health emergency.
I would agree with Dr.
Frederick, I concur with that, and I am prepared to make a motion that we do that.
Okay, so Mr. Frederick, are you making a motion to extend the declaration of public emergency as written to June 30th? That's the only amendment. Is that what I hear?
Yes.
Okay, and then Ms. Franklin, did I hear you didn't actually make a second, but I thought you were about to say I would agree with that, but I don't want to put words in your mouth.
I second that motion.
Right. Any further discussion around this? Okay. All right. I will go do a roll call again. Ms. Johnson, or Dr. Johnson, excuse me.
I concur. Yes.
Okay. Dr. Campbell,
Yes.
Mr. Frederick,
Yes.
Ms. Franklin,
Yes.
Ms. Etherington.
Yes.
Okay. That carries. Thank you. And Derek, you got that now. There, Mr. Smith, we got that. We'll make those amendments. All right. Thank you. Dr. Caldwell, we'd like to report of the director, please.
Yeah, I'm just doing a sound check. Can you hear me?
Yes, we can. Thank you.
Thank you. I am really pleased to provide you an update from the Department of Health. I think each of the board members should be proud of the accomplishments of all of our staff to address this COVID emergency, as well as continuing to sustain our ongoing public health programs and activities. I'm going to divide up my report into a COVID response update, as well as an ongoing activities update. And I've asked each of our ELT leaders to help me providing a picture for you in a bulleted way, some of the challenges that we've had to address this emergency for our community. One of the first things that we decided to do, also with your guidance, Dr. Jahangir, as the chair of the Coronavirus Task Force, is to set up a hotline for the community. And one of the ways that we did that was through the leadership of Laura Barnier, our Bureau Director in Clinical Operations. And Laura's wanted just to give a couple bulleted highlights about how the hotline was put together and some of the challenges. So, Laura, are you there?
I am. Can you hear me?
Yeah, just speak up as much as you can.
Perfect. So, again, I'm Laura Gardner, and I'm going to go over the hotline. So the hotline started on March 25th, 2020. We started 7 a.m. to 7 p.m., 7 days a week. Kept up that same 7 days a week ever since we started. It's mainly staffed by, during the week, by school health nurses, and on the weekends by really staff from all over the health department. We have 3 shifts that occur each day. There's just-in-time training that occurs before each shift. We also have a supervisor there. They work 6-hour shifts, so there's 2 of those a day. We allow staff to sign up for shifts on an internet-based sign-up platform. And our staff are very well versed to provide information about COVID-19 symptoms and refer individuals to the 3 assessment centers. We have seen, just talking about some of those challenges, that we've had to shift our response quite a few times, shifting from the CDC guidelines to individuals over 65 and serious medical conditions to now referring any individual that feels like they need to be tested. We've also added quite a few resources to our just-in-time training, including information about different mental health resources throughout Davidson County, information about masks, transportation options, housing for those that are unstably housed. We work very closely with the results line, the assessment centers, the hub, and the contact tracing team. As of yesterday, we have received 11,150 total calls. Personally, from our hotline, we have referred 3,051 individuals in Davidson County.
Laura, thank you. I know that's just a quick snapshot of all the work that you have done and brought together, not only your staff, but staff across the whole department. Now, of course, after people call the hotline and get assessed and information, and they don't just call because they want to test, they'll call for a wide range of different topics. So we really are serving an important role with this hotline as a behavioral health resource and really answering all kinds of questions that people have. So we're an added system of connectivity for the community. But I've asked Dr. Gil Wright, who's been very involved with the assessment centers, to talk about briefly what it was to get them set up. And now we moved from 3 days a week to 5 days a week. And now we're moved from our partners with the medical systems now to a contract with Meharry. So Dr. Wright, if you could give us an overview of the assessment centers and your work.
Well, real briefly, the assessment centers are called assessment centers because initially we had some limitation in testing. So, and in the medical community and here in Nashville decided that we would do assessments and test those that we deemed at high risk or higher risk, I guess. So that's how it started. We're now testing everyone. We recently went from 3 days a week, as Dr. Pudwell said, to 5. But we've assessed over 13,000 and tested over 12,000 at our testing sites, at the assessment sites. We run 3 sites. They were chosen partly for their convenience, but also because of their location within varying communities, populations, to try and be as accessible as they could be to the community as a whole and subsections of that community. So that's okay. My piece.
Great. And then, of course, once you got your test, you would get a lab report, and we would direct you to either we were using the AEL lab. People would be able to sign in and get their own results, but often we tell people call a results hotline. So we had a special results hotline with another set of operators, professional medical staff who are there to be on call to get those people who were tested what their results were. And Dr. Michelle Pardue from our Community Health Bureau has taken charge of that, and she's going to give an update regarding some of the challenges she had there. So, Dr. Pardue.
Yes, good afternoon. We set up the results line a couple of weeks after the hotline was initiated because we wanted to be able to have a place where people could call in and access their results and take shots at the assessment center. So over the weeks, our volume has picked up, and I think we've had a really, it's gone pretty well. One of our challenges was moving the results line from the Howard office building back to the Lent Center. But we did that successfully, and I think that's made it smoother because we can start to concert with the hotline, and as calls fluctuate in volume, they decreased a little bit to the hotline, so we were able to transform some of those stations into results stations. So now we have 14 results stations, and this week we had our busiest day. On Monday, we received almost 500 calls. So we're already up to over 1,000 in the first few days this week. What we do is deliver the results to folks who visited the assessment center, so they can call in and we have direct access to the AEL database, and we can let them know what their results are and their next step.
Thank you, Dr. Pardue. And now we could not have our work without our great epidemiology investigators and contact tracers. Of course, that's under the Communicable Disease Emergency Preparedness and Rachel Franklin's Bureau. And she's been really leading the way and growing our staff from 4 up to now over 100 not only in just the expertise of what it is to be a contact tracer, but to build a culturally diverse and sensitive outreach. And she also has been very involved with our face masks at distribution. So, Rachel, are you available to give us some overview?
Sure. Good afternoon, everyone. Can everyone hear me okay?
Yes.
Okay, great. So as Dr. Caldwell said, one of the most important things in public health that you can do during this type of event is case identification and very quick contact tracing. So we have actually staffed over 120 people between health department employees who have kind of shifted jobs temporarily, and then temporary workers through our contracted vendor. So we've got about 40 people doing investigations. And what an investigation is, it's actually an interview with a person who has been diagnosed with COVID-19. The investigation is very important. You want to identify as many close contacts as you can. When those close contacts are identified, they're sent to a monitor, and we have beefed up our monitor staff to over 50 people. And those people reach out to these folks who have been deemed close contacts. They explain to them how they need to quarantine and what it means to have been exposed. And then they call these folks every day for 14 days just to check in. How are you feeling? Any symptoms? You know, things like that. So, and then as Dr. Caldwell said, we have an outreach team that's just been put together that can actually go in the field if someone can't communicate through the phone, or if we have trouble finding people, or we just want to engage certain groups that may be experiencing clusters. So we're really proud of that. We had 50 temp workers start just this week, and it's been a very smooth process with a lot of folks helping out. So, and then real quick, our mass distribution event, you may have seen on the news, last Wednesday, we gave out about 25,000 masks to folks from our Lentz building and Woodbine and East Clinic. We are going to have another event like that starting tomorrow and Saturday. We will be at Metro Southeast out on Murfreesboro Pike, giving masks to the public as well. The media is very involved in this. Our phones were ringing off the hook today. Next weekend, when we've had more time to kind of plan, because we didn't know we were going to get all the masks that we got this past week. So we wanted to get them out this weekend, and then next weekend we're actually going to set up locations at 4 community centers around Davidson County so that we can be sure to be available to everyone in the county. So, but that's not going to be till next weekend. Our current inventory of masks is about 180,000, and we have been told through our partners at the state that we could get as many as we need. So we feel really good about being able to do that for our community, and the community is very excited about it.
That's great, Richard. Thank you so much for providing those insights on these very important issues. I've asked our Associate Medical Director in Communicable Disease Control, Dr. Shaw Kaikai, to talk a little bit about some of the challenges we've had, and she's been working on with some of the homeless population. Dr. Shaw Kaikai.
Good afternoon, everyone. The working with the homeless has definitely taken a team approach. It started with 2 of us trying to get those who were experiencing homelessness and were under investigation for COVID from the hospitals to a sheltered place, and the only place we could find were hotels. So having to transport them, we're able to get 3 members of our TB team to transport clients to those hotels and provide food and all for them. And we're happy that this has now gone on to the assistance with OEM and others, and that the fairgrounds have opened up, and also St. Thomas helping with transport. What we're seeing now is that with testing, similar to other cities, is the positive cases in those who are asymptomatic. I know as of yesterday, the 12th, Dr. Wright and some others tested about 50 people who were contacts to a case at the Nashville Rescue Mission. And from there, we're planning on doing what the CDC has recommended and what other cities are doing to do serial testing probably every 2 weeks. And in places like Boston, that appears to have bring down the cases of positives. So just thank everyone for their help. Thank you.
Thank you, Dr. Shaw-Kai. We appreciate your service and all of those who are working with you. Now, none of this could happen without us being able to articulate and communicate to the community at large, and all of the work that we do needs to be put together and translated so to assist the mayor, the coronavirus task force, and all our partners. And we are really grateful to have a great communications director in Brian Todd, and I've asked him just to give a couple bullets of some of the challenges he's faced and regarding COVID. Brian?
Thank you, Dr. Caldwell. Well, good afternoon, everybody. I think, you know, some of the challenges that we faced, if you look back to our first case in Nashville in early March till mid-May, it feels like it's been about 2.5 years instead of 2.5 months. Part of that is, you know, the changing information going back to, you know, before it was here and first here, and along the way, you know, the symptoms, we've learned more and more about the symptoms, or do you use masks or do you not use masks? A lot of the information has changed pretty rapidly, especially earlier on. So it was quite a challenge to keep it accurate. We are all fortunate to have the support. This is a great team in this room, and certainly I couldn't do any of the work that I do without them, especially our EPI staff, Josh and Leslie, done a terrific job. And of course, the support from Dr. Jahangir on the task force and the mayor's office. And of course, we have Matt Peters, who is our social media person getting the message out. And really, I'm especially thankful as we've gone along this process, the support for the local media. You know, they've made it really, I feel like they're such an important, integral part of getting the message out to the public. And even though they've gone through what I've gone through is trying to go through the challenge of, hey, this is changing information, but I feel like that has been something that I've been very fortunate about. And again, I know there's a long road ahead, but I'm very proud of this team, very proud of Nashville for all the work that they've done.
All right, thank you. I know that we are all grateful for all that you're doing to help take all of this information into a way that we can share with all those who ask us for it. Now, one of the other unique challenges that we've faced as a community and a Department of Health is we're not just facing a disease and having to address the disease, but we have issued orders to change our way of life in this city. And we also want to make sure that everyone who's doing their part to keep us safe and to get this virus out of our city, that there are those who are not going to cause us harm. And so we have had to have a very robust compliance enforcement team. And we're really grateful to have the leadership of Mr. Hugh Atkins, with all of his years of experience at the Tennessee Department of Health, who joined us recently as our Director of Environmental Health, to help lead the efforts of our compliance enforcement program. Hugh is here to go over a couple of his thoughts about some of the challenges as well as successes with our enforcement compliance program. Hugh?
Yes, thank Dr. Caldwell. Appreciate the opportunity. Yes, we got heavily involved in compliance early on from the original Order 1 and began to canvass the locations that we otherwise regulate and did 464 consultations between the time Order 1 was issued and amended. And then from March 17 to April 1, we conducted 42 investigations based on complaint. And then beginning April 1, we teamed up with Metro Police to have people accompanying us to complaint locations and conducted 505 site visits up through the beginning of phase 1 this past Monday. They ended up being mostly consultations. We found the large majority of the people were in compliance and cooperating when we got there. We did, however, close 32 places or make them change their operation to curbside. We ended up issuing only 4 citations during that time. They are set for environmental court on the 3rd of June. Those 4 came in the last week of the activities. We noticed the lag time both before the governor issued any orders and the week between the time the governor began his reopening phase to be the most sort of contentious period for us. Intentions began to rise noticeably the last week after the governor issued his order. And Dr. Caldwell and I discussed, and that was a shift in focus sort of going forward, that we would concentrate on education as we went into phase 1, and that's what we've done. We have made already 98 contacts with businesses on complaints that we've received in the first 3 days of phase 1, in those 98 being in places we regulate, the restaurant. We had 155 complaints on retail establishments as well that we don't regulate. Most of those involve masks at places that were deemed essential early on during the whole safer at home process. So we figure they probably didn't pay a lot of attention to the phase 1 opening guidance since they were open anyway. So we're trying to get the word out there that the face mask, face covering requirements apply to them as well, even though they are not reopened. So we continue to do that education. Speaking of education, I've been on a panelist of 5 different webinars on reopening. I'm working with Tom Sharp, his team, and I'm sure he'll talk about that on the phases. MAC made some adjustments, realizing that due to the tornado and COVID outbreak, they needed to shift their focus more to divert intake and rely on community rescue groups, and they were successful in doing that to the point that they keep the shelter population down, and they reported a 400% increase in fostering in April. And that allows animals that are normally housed in the shelter to be in people's homes. So that's a great thing. And just routine business, mosquito season has begun on May 1st, and pools are going to open in phase 2. So we're doing some consultations for those operators to try to get them ready.
Okay.
Thank you.
Mr. Atkins, thank you very much for those thoughts. And you also gave us a little insight of how we're really also trying to continue our ongoing activities. But one of the big things still with the COVID, of course, is the phase 1 and the roadmap to reopening. And what does that mean? And how do we translate that into specifics? Yes, you can do this, or you can't do that. And we have relied on orders to do that. The public health orders, order number 4 specifically on the signage for the masks, and now the amended one to say that the employees must wear masks. And then, of course, now order number 5, which is a companion document to phase 1. And I asked Tom Sharp to chair a newly created technical advisory support team on reopening. And not only has he put this team together, he has created an extension and augmentation of the hub Nashville so that we have an additional call center. It's not a call-in center, it's a call-out center. And we have that in our Charlotte room here. And I've asked Tom to give us some thoughts on some of the work he's doing now on trying to address where we are in our conversations with the community. Tom?
Thank you, Sarah. What happened when we started this process is we were getting the cart before the horse a little bit. We would announce something that something was going to happen, and the details of what that meant were not really clear to the public, so there was a lot of confusion. And we would have a situation where for some period of time, a day, 2 days, there would just be an enormous number of questions that would come in about, does this apply to me? What does that mean for them? So forth. And it got to be really difficult to get caught up on all those things because we got so far behind initially. So when we went to phase one, we wanted to make sure that we had the order in proper shape, the guidance in proper shape, the FAQs that we knew of in advance in proper shape, and have those posted so that people could review all those things before they drowned the hub in question. And let me take a moment here to give my personal and professional thanks to Derek. He has been absolutely fantastic and done an enormous amount of work on all these things. Derek, thank you. So we got the horse before the cart for a change. And so the incoming has not been too bad. We've gotten, as Hugh mentioned, we've gotten a few inquiries about masks, most of which are just a failure to recognize that Order 4 has been amended. But for the general rule, the reopening has been fairly clean. What we're working on now is to make sure that we are trying to take the roadmap when it was put together. Dr. Jahangir could tell you better. I don't remember when it was. I'm not sure what day it is. It was a scientific guess at some level about when things would open and what they should be and what category they should go into and so forth. And so we're trying to keep phase one locked down where it is until we get to phase two, but we've taken a really hard look, and I thank my group, which is John Finke, Morgan Dickey, basically, and Hugh all the time. And then Gil Wright and Leslie Waller have helped us with the medical guidance and EPI guidance to say, all right, let's try to make phase two reflect the actual risk that these various enterprises pose based on what we've learned about the disease in the last couple of months. And so phase two of the reopening will be probably substantially different from what was initially envisioned in the roadmap. And we want to put all that together and follow the same order of business as we did last time, and that is get all the information out. The orders are the actual rules. The roadmap is more or less a suggestion. The thing that's an enforceable legal document is the order. So once we get it out and the guidance and the FAQs, hopefully that we can ensure a smooth transition into phase two as well, whenever that comes. So thank you.
I really want to thank you and all of the work you're doing to help guide so many who are anxious, calling for direction, businesses that want to reopen, families that are looking forward to a wide range of activities, and we want to make sure we are moving slow. So thank you for the work you're doing. I've asked Dr. Michelle Pardue to come back just for a moment because we want to let you know that the work of the Department of Health continues, and one of the populations we're really concerned about is maternal child health in our WIC program. So Dr. Pardue's got an update on what's going on, at least with WIC, just to give you a little sample of the work we're doing there.
Okay, so early on in the COVID response, WIC was concerned about face-to-face interactions, and so they were able to get a waiver to provide WIC services by telephone only to reduce that face-to-face contact. So they were extremely flexible and changed their operation in a matter of days. by telephone. And in a time when other areas of the state were decreasing for benefits issued by WIC, Davidson County increased the benefits that have been delivered in a time when really needs more help. Situations going on where people have jobs and really need help. So, Davidson County across the state is really leading providing WIC services. We do have that waiver until the end of May, so we're hopeful to continue to deliver services. That could be extended, but they've done just a fantastic job.
Michelle, this is hard to hear you. Could you move a little bit closer to the speaker?
Sure.
Oh, good, yeah.
Okay, can you hear me a little better now?
Yes, thank you.
Okay, so we have a waiver until the end of May to provide services by telephone for our WIC clients. And so we hope to continue to be able to do that. And that could be extended depending on how events play out. But they've just done a fantastic job being very flexible and learning new skills and providing these services at a time when our community really needed it.
Thank you, Dr. Pardue. I've asked Tina Lester from Population Health to provide an update on the work in her bureau, especially on the behavioral health issues that I've been very concerned about. Hi, welcome.
Thank you. I will give an update on the presumptive eligibility expansion. We also have a waiver from the state to be able to enroll pregnant women into health care by phone. And we have maintained our numbers as well, working with our staff at home. And that waiver is good until the end of the month as well. Chant, we're doing the same thing with that. Also, we're staggering the shifts so that we can practice social distancing with our staff since they're all in cubicles. So we have staff here on alternate days that sit across from each other. And we've been able to maintain well, we're halfway through the year with that. For the opioid, we know that the numbers are increasing, and we're trying to hire staff for this grant that we received from the Department of Justice as well as from the state. But I don't have the updated numbers for April. I know that we have a significant.
Thank you so much. Yeah, I have also reviewed those numbers, and I believe that the year-to-year, April to April 2019-2020 for overdose deaths in Nashville, Davidson County has doubled and is an indication that we have already had challenges, and the challenges are continuing. We are moving toward a more proactive phase of outreach and compliance, as we talked about with Mr. Atkins and Tom Sharp on the technical advisory support team on reopening. And I've asked Tina Lester and you, Atkins, to work with me to develop a program where we can work with our other colleagues who are reaching out into the community for the outbreak contact tracing investigation with Siloam and Turk, but also with Hands on Nashville, to see how can we best identify community groups in specific targeted communities, such as North Nashville, and perhaps looking also at East Nashville as some pilot programs where we can be able to do a better on-the-street outreach and assessment. So we'll be providing you more information on that in the days and weeks ahead. Along those lines, we are very focused on reaching out not only to the very diverse Southeast community and the Hispanic community there and the other multicultural communities with our partners in Siloam and Turk, focused a lot on the contact tracing efforts. But we also want to work specifically with racial justice in the African American community. And I'm pleased to tell you that I've been working with Mary Falls in the mayor's office, as well as spoke with Council Member Sharon Hurt, the chair of the Health and Human Services Committee there, to construct a webinar specifically through the Minority Caucus to help address some of these issues that are of concern. We know that COVID especially is impacting the African American community in addition to the other communities of the essential workforce. The death rate in the African American community is higher than what you would expect in the population. And we are looking forward to identifying how this webinar with the Minority Caucus could be best constructed and informative for the community. I also would like to let you know that working with the mayor's office and as our focus on COVID response has really, as you see, is a team effort. I've identified the need with Dr. Jahangir for an additional interim deputy director specifically for COVID response. So that will be a companion interim deputy director with the great work that Dr. Stephanie Bailey is doing to assist me with. I have been very grateful to Dr. Bailey for her taking a leave of absence from Meharry to come back to the Department of Public Health to assist our department and assist me with my onboarding process, as well as all of the important work ongoing at the Department of Health. But of course, with all of the work with COVID, and specifically Dr. Bailey has been very helpful to me in the EPI outbreak investigation teams, and in particular, trying to identify a process with quarantining and with the homeless community, with isolation, and working with Derek in legal, as well as our partners in social services and Office of Emergency Management, come up with a seamless system that it works. I know that a number of you have seen the recent news about the Department of Health sharing information with our partner First Responders organization. This is something that started in early April, initially at the request of law enforcement with Chief Anderson and the Office of Emergency Response, because it was very clear that we had a gap in information, and that either residences or patients who were COVID positive, information that we had was not being shared with our partners, and it was causing public health harm that we could prevent. For example, if there was a ambulance or a police officer that was going to a residence where we knew there was a COVID positive case, we would want them to be alert so that they could take heightened precautions. And if they needed to bring anybody from that home or a person to the hospital, that they immediately could inform the hospital or wherever that person would go. If that person had to go to jail, for example, or booking, immediately that person could be identified and precautions could be taken at the entrance of the hospital or at the entrance of a jail to reduce the spread of this disease. And that is our most important concern, is to contain and reduce this disease, to share this information with our public health partners in a safe way. I would let you know that although the jail has had 21 cases of COVID, that is so much less than what we're seeing at other institutions of similar size. Now, all 17 of those 21 have recovered, and I believe that it is because of our intent to share important public health information in a way that is safe and only on an as-needed basis when a emergency responder engages a home or a person, that this information is reducing the spread of the disease in our community, and I honestly believe is saving lives. I have reviewed this with the mayor's office specifically, and they understand that there are other concerns about how this information is being used. And I spoke today with Chief Swan and Chief Anderson and other members of the mayor's task force, and we're going to continue to put all of this information down on currently on what's being done, how it's being done, and if there are other options to share this information. And there'll be a policy discussion chaired by the mayor with bringing together our partners in law, public health, and our first responders to continue on this issue. Now, this was done only after a very comprehensive review by legal to assure that we had the authority specifically from the Office of Civil Rights at the Department of Health and Human Services that this was within HIPAA guidelines, and as a matter of fact, is not something that we could do, but that we in fact should do to address this major public health emergency. So that concludes my director's report, Dr. Jahangir.
Well, Dr. Collin, thank you for a very extensive report that I think is very important for this department and all our board members to have heard all of that. So thank you.
Can I ask a question or just a follow-up?
Yeah, I was going to open it up to questions. So, Mr. Frederick, please.
Yes, Dr. Caldwell, I understand your explanation of the sharing of the with the Metro Police Department, but there is a fair amount of grumbling and concern out there, particularly among the gay activist community. I think this, strikes a little fear in some people who have felt that the information might have been used against them in the past and might be used against people. So I think it's just really important that the messaging is very clear and we get out there, and you're probably going to start hearing from some of those people because, I do get their point, but I also understand why we're doing it.
Yes, thank you so much for bringing that up. And I was trained during the HIV epidemic. I'm very sensitive to that. And one council member brought up this issue and asked me specifically, is information on HIV shared? And I reassure them absolutely not. I'd like to also add to my remarks that we are assuring that the information provided will expire after the 14-day isolation quarantine period. So this is not information that will be on the system longer than needed for knowing that this virus is out of the system. So it's sort of a time-sensitive system, and I'm going to be assuring that those expirations are occurring. Thank you.
Yeah, and I'm not sure who is the main interface with the Ryan White group, but that person might want to just do a little talking with some of those people.
Well, thank you for that information. I appreciate that, and we will.
Okay, and just one other thing and if Rachel is still with us, and you may have answered this, Rachel, but are we able to complete our contact tracing on all the cases within a reasonable time frame, or are we still in need of being able to be a little bit more on top of that?
Go ahead, Rachel. I just checked it. Yeah. Okay. Excellent. Go ahead.
Yes. David, we've been able to consistently contact these folks once we've learned their name and contact information within 48 hours.
Okay.
Now, what will delay that is if we have trouble getting into contact with the actual positive patient, or if we have issues kind of getting information from them that will help us, to identify those people. But as soon as we get those names, it's usually within 24 hours, but never beyond 48. And then, as I said, they'll be called every day for 14 days after that.
Okay, thank you. That's all I have.
Thank you. Any other board members have any questions?
Yes.
Yes. So,
Sorry.
Carol, you go
Who's it?
first. I have several questions, so we might want to get prepared.
Well,
Okay, so who's going first, Carol or Tanae?
Yeah, I'll go first.
Carol, please, and then when you're done, Tanae. How about in that order? So I won't have to keep jumping in. So thank you.
Okay.
Carol first.
Okay, well, what I would really like to know about the decision for release is a bit multifaceted. One, if this started in early April, how do we not know about it until May that it was going to happen? Two, one of the very consistent things that's been so impressive from the press conferences is that it seems like decisions have been made based on metrics and science. So what I'd like to know is what were the metrics, what's the science to make this determination, even though the governor said that he did it and he was, I think, lobbied by a lot of the more rural places, understandably. But I still am trying to grasp Nashville, Davidson County, and largely because those of us who've worked a lot in the community rather got bombarded with some calls, concerns, which are quite legitimate. So I really would like to have a more definitive understanding of how we arrived at that. What was it based on? I understand, and I'm a super supporter of law enforcement for a host of reasons, but I still don't get what prompted the decision. The second part, and then I'll turn it over to Tanae, is with regard to the partnership. The populations that would be most concerned about this are populations that you have described, Dr. Caldwell, as having partnerships with. Who within our department is charged with really spending time to be partnering and talking with them so that they can educate us about the issues and the concerns? And any partnership, obviously, needs massaging from the very beginning if it's going to be sustainable and if it's going to be effective. So I don't know who with the foreign-born. I don't know who with the vulnerable populations, the racial issues, and the population David's talking about. How are we going to really prioritize partnering with the people who are most closely aligned with those different groups?
All right, thanks. Well, Dr. Caldwell, why don't you answer those, and after those, Ms. Franklin.
Actually, it might be more efficient with our time for me to add to that particular question, and then I do have other questions. Regarding the release of information to law enforcement, when I found out personally through the media, and if this decision was made in early April, why wasn't the Board of Health informed that this was even a possibility? If the decision was made after our April board meeting, why wasn't it communicated to us in some form or fashion that a decision had been made or that this was on the table? It's very frustrating as a Board of Health member finding out this information after the fact from the media, and then building Mother's Day weekend, receiving calls from the community regarding this concern. So that's sort of piggybacking on Carol's question. My other question related specifically to the disclosure of testing results, positive results to law enforcement. At the time of testing, at any time since this protocol has started, has it been disclosed to the person or the patient receiving the testing at the time of testing that their results, if positive, may be shared with law enforcement or any other entity outside of the traditional HIPAA protections? I know that HIPAA allows for this, but with regards to transparency and just the patient understanding how their information will be shared, has it been communicated to them at the time of testing? Again, this is very frustrating for us as board members to hear about this after the fact. In the Black and brown communities, it has significant implications, particularly because of the relationships, the strained relationships with law enforcement. The last part that I'd want to ask, if the Board of Health was not informed about this, was the Community Oversight Board in Nashville, Davidson County informed that this protocol was being thought or that it was actually implemented? And I'll stop there for this particular issue.
Okay, well, thank you. This is Dr. Caldwell. I could tell you what prompted this decision was a request, and it's not just by law enforcement. They're just part of our other emergency response community partners that was very concerned, not only about what was going on in Nashville, Davidson County very quickly from mid-March to early April, but what we were seeing across the country, in particular New York, where we saw first responders getting sick and dying at unbelievable rates. And when I went to legal to check whether this was compliant, I immediately reacted instinctively as a basic public health practice that all of these people are part of the public health system. And I had no recognition that this was something that would need a Board of Health approval. I'm the Director of Public Health, and certainly I need your advice and guidance. And I am with the Office of Emergency Management every day. I do not do anything without the advice of legal, and I am here to address this unbelievable challenge that we have in the best way possible. And so many of the first responders also are from the communities that you discuss. And I am so grateful that we have very actively tried to prevent this disease and save lives. As for HIPAA, we are fully within the rights to be able to share this information with other medical providers, the hospital, and anyone who is part of our system. Now, it's impossible for us to be able to provide this sort of consent that you're discussing because we get lab reports from all over the country. The lab, wherever you get tested for COVID or any infectious disease, the report goes to Nashville, Davidson County. For example, we have people in Tampa, Florida, where they had a COVID positive case, and their residence is in Nashville, Davidson County. So there are over 40, 60 labs that have this, and we don't know what all of their processes are regarding what they inform them. So it's really not possible to do. Now, the other question regarding the partnership, there's not just one person who is in charge of partnerships. I, as the director here, I'm doing my best to be the leader of all the partners, but we are so lucky, especially in the Bureau of Population Health with Tina Lester's group, but all throughout the entire Department of Health, we partner with so many other agencies and individuals, neighborhood health clinics. So it's not housed in any one particular area, but those places that you're thinking of, I think, are probably based a lot in Tina Lester's bureau, and I am working specifically with her now to think through how we can reach out to certain members of the community. But some of these we're building from the ground up, not completely the ground. We do have a foundation and infrastructure of partnering across many communities, but what an opportunity this provides us now to build really strong contacts with Siloam and their community health worker program, to reach in and engage communities that have been hard to reach. We have our Woodbine Clinic and our East Clinic, as well as all of our programs which reach out into the community. But we're going to use this opportunity with COVID interactions and response to strengthen all the other programs that we have in public health. And also with TIRC, the Tennessee Immigrant Refugee Community Partnership, we are building bridges and strengthening bridges that we are really grateful for them engaging us. And they understand that we need them to help us, and we do not want to have education coming from places or people that they don't trust. Trust is important. So I really believe that this is a challenge that we are facing. So that concludes my response. Thank you.
Dr. Caldwell, we are, up until this week, when Meharry took over the assessment centers were largely under the purview of Metro Nashville. So again, for those assessment centers, particularly where we have control over that situation, were patients that came in for testing informed about the relationship of sharing data, health result data, with law enforcement?
Law enforcement is part of the emergency response community, and as part of HIPAA, there was no requirement to do that, and it's not done.
So the answer is no. Is there a plan to start to disclose that for each person that comes in for testing at the assessment center or anywhere else? Is that a plan of communication for Metro Nashvillian to get tested, that they will know that their information may be shared, will be shared with law enforcement? Is there a plan to make sure that we have language to share that information for any person that receives testing in Nashville?
This is not something that has been addressed.
I encourage the department to address it ASAP, please.
I think, Ms. Franklin, I would agree, and I'll make sure to take strong partnership with Dr. Caldwell to address that issue in that statement.
I recognize that I recognize I've taken a lot of time. I do have another question related to law enforcement that's slightly different, but since that's where our conversation is, I'd like to go ahead and ask it, if that's okay.
Yes, ma'am, please.
Okay. So I think it was last month at the board meeting, or maybe in another conversation I had with maybe Dr. Wright or Dr. Caldwell at some point, one-on-one conversation, I asked about protective equipment or masks for law enforcement officers of Metro Davidson County. I was asking, one, because it is important for our law enforcement to be protected because they are on the front lines. And since COVID is shows up in people as asymptomatic, they can also be vectors. Any of us can be a vector. So I asked about masks. I understand that now we have sufficient masks for law enforcement. However, in North Nashville, about 3:25 this afternoon, I was driving and I saw a situation in which there are two fire department individuals, three MNPD individuals gathered around a gentleman. So they were helping him. None of those first responders had masks. So my question is, what is the requirement and how are we enforcing our first responders, fire, and police with regards to wearing masks, particularly as they're coming in contact with residents on a regular basis?
Well, yeah, thank you for that. I think you really bring up an important point, and it's all starts with leadership. And I can tell you that this is something that Chief Swan and Chief Anderson, who oversees fire, EMS, and police, are very much concerned about and want to change the culture of their employees. I just shared an email that Chief Anderson sent to his entire police force talking about his use of masks and how important it was. So this is a really important example that you bring. I hope that you share it also with Chief Anderson and Chief Swan, because there is more work to do. It is not part or natural culture yet, and it has to change. And I can tell you that I am convinced that Chief Swan and Chief Anderson are absolute partners in wanting to move us forward to assuring that their staff are using masks as appropriate, as directed, because it is a learning process and it is a public health concern. And I will bring this up to him specifically to say I expect them to try better, to do better, because ultimately, Ms. Franklin, you're going to tell me, and we get hub complaints like this, and I'm happy to get them and catalog them because it helps me figure out where I need to prioritize my time and attention. And the notion that we've got to change the culture and have people more accepting of masks being, I am wearing a mask to protect you. I show you respect by wearing a mask. If you don't wear a mask, you are not showing respect or protecting me is of paramount importance. So thank you for raising this.
All right, thank you. Any other questions, comments in the room or not in the room?
Yeah, Alex, I have one. If I don't want to monopolize, I think Tanae and I have sort of done there.
I think this is good. I think it's important to have this dialogue. Please.
It isn't about this issue, although I share so many of Tanae's concerns, and especially I think it would have hit us. I'll just say I think it would have come to us differently had we had direct communication with you, Dr. Caldwell, about the fact that this was evolving, and that doesn't mean that you have to tell us, because I think the last thing we want to do is dig into operations. But this is a huge concern for many of us who work in this community. That the reporting, I mean, the testing is going to go down because people are afraid to be tested, and that's why I was asking for the science and the metrics to say that yes, this has not proven to be over time in any place a detriment to it. But going along, my other general question for anybody, Laura or whomever has been involved in all the centers and the hotlines, et cetera, are we okay with volunteers? Because there are a lot of people who are saying that they would, and especially as I'm sure you have known, there are many faculty who are wanting to have students over time be engaged if there's a way they can be helpful. And or retired folks who cannot be on the front lines, but who would be willing to do it. I just wonder if you see in the future there may be a need, or if everything is taken care of.
Hi, Carol, it's Laura. Can you hear me?
Yes,
I can. Happy Nurses Week.
Oh, yeah, same to you. Happy Year of the Nurse. Didn't know we were signing up for this one, but
really? Okay.
I did want to let you know we have already engaged. It was another part of my update. We've already engaged with some of the Belmont nursing students. So at all 5 of our Metropolitan Health Department, Mac, East, Woodbine, we will have it at South Nutrition when they open back up for services, and Lynn. We have students stationed to be able to do screenings on all employees and all visitors to those areas. So we're engaging with those. I also have Emily Morse working with getting them involved with the hotline and the results line. If you have any volunteers or anyone else that you can think of, I will take them. So I know.
Okay, well, that's really important, I think, for all of us to know that you do want it, because I don't think any of us want to bombard you with people calling, but you may have some retired folks as well as students, and I'm thrilled that the Belmont students are in there. I heard that from a joyful faculty member over there. There are other schools that may want to do it, but you tell us how best to funnel that info to you, and to whom should they call?
This is Michelle. I wanted to let you know we do have a link set up for a medical reserve corps, and I can send you that so that volunteers can put their names in that registry, and then we can reach out to them. So that might be a little easier.
That'd be great.
All right, thank you. I'm looking at this. I see Mr. Frederick has his hand up. David, is that still something you want to talk about, or you've already asked your question? All right, hands off. Ms. Franklin, I see, has her hands up.
Yeah, I have 2 more questions. I'm going to put them out at the same time so we can move on. My first question, and this is regarding follow-up, particularly as we're contact tracing and keeping track of patients for 14 days and they've tested positive. Have we lost patients to follow-up? And if we do, what is the plan, particularly if they test positive? Just what is the plan if we lose patients to follow-up? I know that there might be home visits, but if that's not successful, what is the plan beyond that? Does law enforcement get involved? And then my other question is related to the National Guard coming in to our public housing areas, and I know that's being coordinated by the state of Tennessee. What relationships has the health department had with the state of Tennessee or with the National Guard regarding testing that's happening in our city limits at Metro Public Housing?
Okay, this is Dr. Caldwell. I was going to ask if Rachel, are you still available?
I am, but as far as what happens if we can't follow up with someone, that Dr. Bailey and I know Derek, they've really worked out the legalities of what we can and can't do, and I'm not clear on that.
Maybe Derek is.
I've asked Dr. Bailey to provide us a little more insight. Thank you, Doctor.
Absolutely. So one of the things in our public health authority, we do, it goes clear up to arrest, and it's a progressive process. And most of the things that we do do not lead to arrest. So when we have someone that we have lost contact with, we will make first of all, our DIS workers will go and try to find that person. And yes, the police will help us as well look for that person. And when that person is found, like we've had one instance, they are encouraged to go back under their quarantine. And most people do volunteer. If they do not, then it can lead to an administrative judge order for enforcement, just like with TB or hepatitis A or any of our other notifiable reportable diseases.
Thank you, Doctor. The other question regarding the MDHA, I've been working with Councilmember Sharon Hurd and Jim Harbison early on their pilot programs for housing. Once they contacted Meharry to expand that program, I just encouraged them to continue on and was grateful to them. The Department of Health in Nashville, Davidson County has had no relationship with the work they've been doing with the governor's directive to test the Metro Department of Housing. We have learned about it just as a parallel about who they were getting to test. So we are not involved with that other than just trying to be supportive of Mr. Harbison and trying to get the word out that it's important to be tested, and we hope that people will be tested, but we've had no contact with the National Guard here at Nashville Metro Davidson. So
okay, thank you. Just a quick follow-up to that. If individuals in the National Guard testing, if they test positive, who is responsible for contact tracing? Is it the state or is it us?
Well, just like any test positive, the positive test goes to that person's place of residence, and that place of residence, if it is a Nashville, Davidson County residence, it comes to us here, and our contact tracers will test it. So of course, you're right. If their housing is in our area, we here are responsible for the contact tracing. So that's kind of how it works. Did I explain that correctly? Did you understand that?
Yes, thank you.
Oh, okay, thank you.
Any other discussion? I appreciate this. This is good. I think I'm really glad we're having this dialogue. Anything else? And otherwise, I'll move on the agenda.
Well, just I think for asking perhaps the next meeting we have, it may be helpful for those of us who are affiliated with universities, et cetera, to hear your thoughts, Dr. Caldwell, about if schools open up, and it may be beyond universities, I don't know, but I don't think we've got the manpower to attend to contact tracing across the swath of universities, but that is going to be a question that arises. And could that be discussed a little bit as to what you see the role of MPHD being with universities, and since we have 14 or 15 in this city?
Well, yeah,
should they decide to open up?
Yeah, if you're talking about, we can have a continued conversation about that. I'm just so pleased to let you know that on early March, we started out with just 4 contact investigators, and now at the beginning of next week, we're going to have over 125. So we're able to handle this right now, and we are continuing to prepare ourselves as the city and the roadmap for reopening continues, that we are the most important sentinel to assure we got to do as much testing and lab capacity as possible, and contact tracing is important for us to identify any cases, get them isolated, quarantine in these clusters. And one of the very first clusters was from Vanderbilt. So we are concerned about that, and we will plan. And I really look forward to continuing this conversation.
All right.
Good. Thank you.
Anything else? I'd like to present. All right. Hearing nothing, thank you. Again, thank you, everyone, for your participation in that discussion. And we can come back afterwards if need be. Mr. Diamond, you have grants and contracts, please.
Yes, Dr. Jahangir, we have one application that was included in your packet. It was for MAC, Preserving Families Partnership with PetSmart Charities for $50,000. Entertain any discussion if there is any. If not, somebody could make a motion to approve.
Anyone motion for approval, anyone?
Move to approve.
Ms. Etherington, a second.
Second, Dr. Johnston.
Thank you, Dr. Johnson. Any more discussion regarding this? All right, do a roll call. Dr. Johnson.
Yes.
Dr. Campbell, excuse me.
Yes.
Mr. Frederick.
Yes.
Ms. Franklin.
Yes.
Ms. Etherington.
Yes.
Great, thank you. All right, Ms. Diamond, next.
Yes, Chair Jahangir, there are 13 grants and contracts for approval. I don't know if you'd like me to go through them one by one. They were all included in the advanced packet.
Thank you. Any question or dialogue or motions regarding these?
Sorry, I do. Carol here.
Yes, ma'am.
One is if you all could generally with the Ryan White grant, 2 questions, and I'm asking it now, even though it's not the specific thing about the COVID grants. Who are our partners on these COVID grants?
They are our regular contracts that we have the Ryan White Part A. So it's the same ones, Nashville, Harry, Vanderbilt.
Okay, and the other question I have is more general, and that's because of concerns I've heard in the community largely, and it's my concern too. Typically, the Part A, this is not COVID necessarily, the Part A Ryan White funds are issued by March, and they have not yet been issued, to my knowledge. Can you correct me and or tell why that would be so prolonged? Because I think there was an issue in February, even before COVID came along. And I don't know who wants to answer that, but
I'll speak to it, Ms. Etherington. We sent all the required information to purchasing well in advance. We have exhaustively tried to have these contracts moved along. And yesterday afternoon, I spoke with Mary Jo Wiggins, the deputy director at Metro Finance. She actually contacted me about this because she had heard something from one of our contractors. asking about it. And so this has reached the council level. I believe over this past weekend, there was an inquiry to a council member and separately to Metro Finance. So there is some holdup between purchasing at Metro Finance and legal. This is something it's a great cause of frustration for Tina's group and for my group in finance, as well as everyone. And we have talked with everyone we can to try and move this forward. Tina, do you have anything to add?
And we are still getting invoices from the contractors, and we are paying them, and people are still getting their services. So we're not delaying services.
Well, and if there's anything that we can do to support your efforts on this, because my concern is, even though people whom you work with a lot in these partnerships, they know, I think, that it isn't the health department. However, I think there are others who are not clear that it isn't the health department that's holding up the money, and it isn't. But I really wanted to ask you directly about that. So.
Right. No, Tom engaged in conversation with one council member either over the weekend or early this week. And as I said, I discussed with Mary Jo Wiggins late yesterday afternoon about this. So we are trying to push this as best we can.
Thank you.
All right. Any other discussion?
This is Dr. Johnston. I have one other question. It's just a detail. It says contact on page 14. Dr. Long is still listed as a contact person. Is that just how the grant was submitted, and that that's really not an issue anymore? Page 14.
HRSA, that federal?
It is the HRSA. That was the previous one.
Right. Yeah.
It's Sandy and Dr. Long.
It will be. It'll be changed. Yes.
Thank you.
All right. Thank you. Any other discussion? If not, I'll entertain a motion to approve these.
So moved.
Is that
Second.
I'm sorry, just for the record, was that Ms. Franklin that made the initial motion?
Dr. Johnston.
Oh, I'm sorry, Dr. Johnson. And who was the second by?
Dr. Campbell.
Dr. Campbell, thank you. Any further discussion? All right, if not, here's my roll call. Dr. Johnson.
Move to approve.
No, yes, this is the vote. Dr. Johnson?
Yes,
thank you. Yes. Dr. Campbell?
Yes.
Mr. Frederick?
Yes.
Ms. Franklin?
Yes.
And Ms. Etherington?
Yes.
Thank you. Okay, so it's now up to my report. I mean, my gosh, I want to first begin by thanking all of you for your commitment to this board and oversight, advice, friendship, guidance, to say the least. So thank you all. Dr. Caldwell covered a lot of things I wanted to cover. What I am proud of is how the community has responded to the contact tracing numbers, the testing numbers. I think there are still things that we can continue to do to serve our community well, and we're and better. And we had some of those discussions today, so thank you for that. I'm not going to take too much time here because you guys probably get tired of hearing updates daily. But essentially, we're now 1 week into phase one. Next week we'll have a discussion looking at the data to see if we can roll into phase two. And ideally, if things look good, we'll roll into phase two by a week from Monday. But again, Mayor Cooper, Dr. Caldwell, and I and others will I'm sure have a nice discussion around that in next week once we get the data. That's my quick spiel. So I appreciate it. Any other discussion or points before we adjourn this portion of the meeting?
Thank you to this entire workforce. You have made us all extremely proud, and I know we each think that, but I just wanted to say it out loud.
You're here. All right.
I really thank you, Dr. Caldwell and ELT, for your quick hits you report out. It's helpful to sort of hear what's going on in all of the bureaus, and so thank you for being here and preparing for this meeting and sharing. And thank you to your teams as well.
Great. Thank you. I'm going to adjourn the Board of Health meeting and open the Civil Service Board. So imagine my imaginary gavel 1 and 2. And now Civil Service Board, Mr. Diamond, approval of fiscal year 21 pay plan. Mr. Diamond?
Yes, sorry. My thumb didn't hit the power button. Not sure. You hear me now?
Yeah, we can hear you.
Okay,
Mr.
sorry.
Diamond.
Are we into the approval of the pay plan?
We are. Pay plan.
Okay. Yes, members of the board, as part of the mayor's proposed budget, he proposed no salary improvements for Metro staff members. So we've put forth a pay plan for your approval that has no cost of living, no merit or step increases for our employees. And that is required. It's a status quo from the current one because there are no improvements included. So I'll entertain any discussion if you would like.
Okay. Do we need to approve this?
Yes, sir.
All right. I have a question, but I don't think it's relevant to this. But let me ask it in case it is, if I may. When the mayor announced the $3.13 hazard pay for employees who are directly involved in obviously there's rules around directly involved in response to COVID. Since we are an independent civil service board from the rest of Metro, is that 313 also get applied to our employees who may fit the description of what a hazard pay warranted employee is? Is that something, I don't know, again, maybe not relevant to this thing, and if it's not, you can tell me it's not, and we can vote on this and then come back to this question in a minute. So
it's not relative to the pay plan, but I can answer it for you if you would like.
Let me vote on this, and then I want that answer. So any other discussion around this pay plan statement? All right, is there a motion for approval?
Motion to approve. This is Tanae.
Thank you. Second?
Second, Carol.
Thank you. Any more discussion? All in favor?
Aye.
Aye.
I'm sorry, I didn't have my roll call. So I heard Johnson, Campbell, Frederick, Franklin, and Etherington. Everyone agree? Okay, thank you. No oppositions. Yes. All right, thank you. This carries. Okay, so now back to my question, please, Mr. Diamond.
Yes, sir. As part of the hazard pay funding, the organization was required to have a hazard pay policy in place or part of the civil service rules, which we did not. We are in process of drafting such a policy and plan to have it before the board at the June meeting. Unfortunately, we would not have any of our employees qualify. I think just based on the rules that were set forth with that, very few of our employees would have qualified anyway, even if we did have a policy in place. But that is something that we are addressing and will bring before the board in June.
Could you elaborate as to why our employees may not qualify?
Yeah, thank you.
I don't have the exact language in front of me, but words are that employees would have to have repeated exposure to COVID positive or likely COVID positive patients or clients or anything. And we don't have a lot of our employees out in the field performing that work. There are some.
Right. So can I make a statement? My statement is this: we may not have that now, but we have to anticipate if perhaps, God knows what happens with this virus down the road. I very strongly recommend this. I'm glad we don't have anyone at this moment, but I strongly recommend we follow similar rules as the rest of Metro, especially given this department and God knows what the future may hold with this virus. So I would ask that that's something that we get in line with the rest of Metro government as soon as possible. And if that's next month, that's fine, as long as you're telling me that no one currently who should be getting that pay is not getting that pay.
Right, that's the plan, and we've had discussions about that over the last week or so. Dr. Caldwell and Les Bowen and myself. So,
all right.
As I said,
another time, Jim.
Okay.
Thank you. Any other discussion? All right. Hearing none. How about? And then there was a list. There's a list of personnel changes. Any discussion around that?
Well, I just would like to ask, we've hired an interpreter. Do we anticipate needing to do more of that, or are we good?
I'm sorry, you broke up just a little bit. Did you ask if we were going to need
I just
more?
wondered if we have a plan and or are we okay with funds if we have to add interpreters?
Our interpreter staff for our regular operations is good. We did see quite a large increase in our telephone interpretation services bill in the last billing cycle for that due to all of the COVID-related issues with maybe the hotline. And I don't think the results line has used it yet, or it's reflected in the billing, but our results line is using it. And we will be using CARES Act funding to pay for that. But Mr. Olindi, the interpreter, is our new Arabic language interpreter. One of our previous Arabic language interpreter took a promotion to a different position within the department. So this is just a regular position, but we have utilized our telephone interpretation services quite a bit during these last 2 months. And we are using our telephone interpreter services through our hotline. And now Dr. Pardue is confirming with our results line. So we are very well placed with our telephone interpretation services. Our employees are well versed in how to use that. So we have been using quite a bit.
Thank you. That's great.
All right. Any other discussion? Okay, hearing none, I will adjourn this meeting. Thank you all so much, and we'll see you or hear you next month.
This has been a service of the Metro Nashville Network. If you would like to see this presentation again, or for more information about this and other programs, visit nashville.gov.